So without further ado, I'd like to introduce Dr. Marvin Berman, neurofeedback and photobiomodulation expert. I've known Marvin and we have worked collaboratively on a number of different individuals, just like with Dr. Harsfield, but I've been working with Marvin for a lot longer time. And what I'll do is I'll help, and Dr. Carter will help change the physiological terrain of an individual. And I always have I say the same thing over and over again. When something like photobiomodulation works, that's great. When it doesn't work, you know why. And I think it's important. There's where it's important to do physiological tests in concert with these energy medicine techniques. So without further ado, Dr. Berman, why don't you introduce yourself, really your history, your background, and then let's get on with the show.
Great. Thank you, Tom, for having me here. I really appreciate the opportunity. My name's Marvin Berman, and I have been studying kind of the mind-body problem for a number of decades. And I started out as a psychologist and very interested in the relationship between mind and body, and was trained in the Neo-Reichian psychoanalytic approach to psychotherapy that in the USA was called bioenergetic analysis. And that was a way of understanding how people's early experiences and their psychological development had a direct correlation to patterns of chronic muscular tension in the body. And that psychotherapy really was important to recognize that you were working on a body level as well as a psychological level. So when I started to work with patients, probably about 24 years ago, it was 1996, a patient came to me who I'd been working with for 5 years, and he was getting ready to terminate. And I said, this is great, but tell me how you're doing. And he's like, oh, well, things are great, but sometimes things don't click. And he did this. And I'd never seen him do that before. And I said, what's this in English? And he said, oh, sometimes things like move around on the page when I'm reading, or I have to read things 3 times. And, it gets annoying, but, otherwise my life is really great. And I was like, wait, back up. What else is going on? Well, I have these, this problem. I said, how long have you had it? He said, oh, years and years. And I sat back and kind of offhandedly said, what, you got hit in the head? And he said, what, you mean like a car accident? No, I never had a car accident. So then I sat back and went, wait a minute, that's not what I asked you. Did you ever get hit in the head? And he went, oh, I fell down the basement steps when I was 3, and Johnny hit me with a baseball bat, and I rode my bike into a brick wall when I was, 16. And I went, wait a minute, you're not neurotic. You've got brain damage. Now what do I do? And it was at that moment that I realized that there was a way in which I couldn't work with people if they had something that wasn't psychological, that it was an actual brain trauma. So then how do you deal with that? So I had to go back and retool myself to understand neurophysiology and neuropsychology, and then how you would treat somebody with brain injury. So that obviously became my third question on intake from then on. And I went back and looked at my caseload at that point. And as it turned out, 70% of my caseload had a traumatic brain injury history of some sort. Mild, but some people had serious, they got knocked out in a fight. So I started saying, oh, there really needs to be a way to deal with this. So I worked on developing a technique that was shared with me by a neurofeedback therapist who was a friend of mine. And I brought it back and I used it with this guy and with another patient. And they said, oh, they did 6 or 7 sessions, and they came back and said, oh, well, that was great. Okay, that's done. And I said, what do you mean done? It's like, oh, those problems are gone. It's not happening anymore. I was like, what? And they were like, yeah, it's gone. I was like, okay, great. So I just put it in the closet thinking that was going to be something I would deal with later on. You know, if somebody ever came and they said, oh, I have a head injury, we take out this gizmo and we do a bunch of sessions with them, and that would be that. Well, then they came back and said, you know, I don't know why, but I went to my allergist and they cut my theophylline in half because they said I don't really have asthma anymore. And I was like, and they said, whatever that was, it really helped my asthma. And I'm like, what? That was for your brain trauma. They were like, I didn't do anything else other than that. So, you know, you can argue with me, but then another woman came back who I'd been treating, and she said the same thing. Oh, my doctor took me off theophylline because I don't have asthma anymore. And that's when I kind of went, I better check this out more. So I went and checked it out, and that's where I discovered the whole idea of neurofeedback. And this whole idea of neurofeedback as a way of retraining central nervous system activity by rewarding specific patterns of electrical activity in the brain. So we started doing this research about this because in the area of dementia, because I was really interested in that. My mother and my grandmother and other people that I knew had died from dementia, and I wanted to know what could be done. And I saw that neurology had been studying the EEG of dementia of patients for many years, and there were many publications, but they all ended up saying the same thing. The slow brainwave amplitudes go up, the fast brainwave amplitudes go down. So then I started looking for, okay, so now that you know that, what did you do about it? Nothing, because that's not what they do. They didn't know about biofeedback, or if they did, they didn't use it. So that's when I realized that there were these two silos of knowledge. The people in the neurofeedback world were not publishing papers in the Journal of Neurology, right? And the neurologists were not publishing anything in the Journal of Neurofeedback, and they certainly weren't reading the Journal of Neurofeedback. So they didn't know, for instance, that the first line treatment for seizure disorders is not phenobarbital or dilantin or Keppra or any of those sedative hypnotics. It really was, or Tegretol, it wasn't any of those medications, it was neurofeedback, because it was the less invasive thing before the more invasive thing, which is how we're supposed to approach treatment. So doing biofeedback is certainly a lot less invasive than taking, you know, Tegretol or Keppra. So when I saw that, I said, okay, let's do this research study on people with dementia where we could show what happens to people when they are struggling with dementia, but they learn how to decrease the activity in the brain. So I'm just going to skip to that slide, but I'll get back to who QuietMind is. But what we found when we did the study with about 27 people, half of whom were treated in the clinic and half of whom were treated at home, we actually sent equipment to people's homes and taught them how to use it. So the caregivers were delivering the neurofeedback training instead of Dr. Berman with, you know, however many years experience I had. We wanted to show that it really wasn't about the doctor, it was really about the training. So when we did it, we saw that there was no difference between the groups in terms of outcome, but the people who learned how to decrease the slow wave amplitudes, right, which are these folks, right, the less red means the lower incidence of that amplitude. Those people also showed significant increased activity in these red areas that had to do with mid-range and faster frequencies, which are associated with higher levels of consciousness and attention. So those people who were able to decrease the slow wave activity and increase the faster activity, in fact, increased on all of these different neuropsychological measures of memory and cognitive functioning. So that told us that neurofeedback could be a non-invasive, non-drug way of intervening with people who have neurodegenerative conditions like Alzheimer's. However, we didn't treat the Alzheimer's disease. These people still had a chronic neurodegenerative condition. So what we did was change the slope of decline, but we didn't treat the underlying pathology. So people were still getting more disabled, but it was happening slower, which is a good thing for the family. And it was, it gives families a sense of hope. But we knew that we'd only kind of figured out a part of the problem. In the middle of that study, one of the husbands of the people we were working with sends me this email, and the subject line is, "What the hell is this?" And there's a link to the Daily Mail in England about with a headline that says, "UK researchers reverse dementia using infrared light." And I'm like, oh my God, this poor guy, he's desperate. He's reading the Daily Mail. And this is a PhD chemist who runs a multi-billion-dollar company. So I was very surprised, but then I read the article and realized that it was an article published in the British Journal of Neuroscience. It was just a description of the study. And then I went to the research and I read the paper and I read the background, and then I realized these guys are not kidding. It was an animal study that showed that the animals that got stimulated in their cages with this 1070 nanometer light, those animals improved significantly on a radial arm maze trial. So their memory did in fact improve significantly compared to the normal placebo mice. So this all got me into thinking about what's going on with the mechanism of action, like what's really going on here. And that's when we started to understand that what we're doing is influencing the activity of the mitochondria in all of our cells. So all mammalian cells have mitochondria. So we started to understand that the light was influencing an increase in the production of adenosine triphosphate, the ATP, and that was helping to allow the cells to not only repair, but also protect themselves against further injury. And we started to look at all the research that was being done at Durham University in the UK by Professor Chazot, Paul Chazot, who's on the faculty in their molecular science division, and saw that there was a very solid level of bench science about how light, specifically this frequency, this wavelength of infrared light that was pulsed into the cages, into the animals, was significantly changing the way in which their mitochondria was operating. So that's when we started looking at more and more, what are the different impacts that photobiomodulation has on the body? And we saw that it has kind of apoptotic, cell death. It also helped with the overall survival of the neurons. There was certainly cell migration changes. There was an anti-inflammatory process. There was a decrease in edema. There was an increase in the neurotrophins, also in the heat shock proteins. I mean, there was a great deal of things that we started to see. And one of them that really struck me was the fact that the endothelial tissue in the blood vessels was being stimulated, and that there was then an increase in the flexibility of the microcapillaries in the cortex. So the normal effects of aging on atherosclerotic processes in the endothelial tissue, the microcapillaries getting stiff and not being able to expand, was being directly affected by the light. And so these blood vessels were able to increase. There's a recent paper, almost 20 microns of increase in the width of the blood vessel. Well, that immediately means that there's more blood flow, more oxygen, better chance of survival, and all of these other factors then can come to bear. So that really got us very excited. So we started thinking about overall, what were the mechanisms of action? And we saw that there were the ion gating channels that were modulating transcription factors. There was the protective aspect of the heat shock proteins and growth factors that were being increased. There was a direct increase in nitric oxide and reactive oxygen species inside the brain. There was an increase in the cortical and the free-floating mitochondria in the blood. and that led to an increase in ATP synthesis. So now that we know that there's mitochondria in the blood, right? Some of these interventions that involve putting the light in your nose, like we have a device that we've found that you can just, stick it in your nose, push a button, and you're getting 810 nanometer light into your face, and it's going to stimulate your entire body's blood supply, right? In 20 minutes, you'll stimulate your whole body's blood supply 5 times. So that was very interesting to us. We also saw that we could then entrain the EEG amplitude and the connectivity, which is called coherence, in the brain, in the neuroelectrical activity. So this started to help us really see that if you put these two things together, right, the photobiomodulation, the infrared light, and the neurofeedback, that you really had a synergistic potential there that was really interesting and might really add to the clinical impact that we could see with people with neurodegeneration. So that's basically what we're working on now, is this idea of photobiomodulation, which is using light energy to stimulate, heal, regenerate, and protect tissue that's been injured, right, is degenerating or is at risk of dying. And so there's even the possibility that we can now see, because of a recent study that Professor Chazot published, is that photobiomodulation can be used for cognitive enhancement in normal, healthy people. Yeah, they just released a paper on that, showing a 20% increase in memory, a significant increase in finger dexterity, and an increase in overall cognitive processing speed in people with no neurodegenerative condition, just ordinary older folks who, forget where their keys go, but basically normal folks were getting significant improvements. So what that leads us to now is being able to talk about the idea of using these tools as a preventative measure, along with the functional medicine approaches that Dr. Carter and Dr. Lewis are doing, that functional medicine now fits in as the way to deal with the underlying toxicity issues, the inflammatory issues, all of those components that might be leading to neurodegeneration can now be added to and supported by the photobiomodulation. Neither of those two interventions are actually going to renormalize the disturbed or disrupted neural connectivity patterns. That's an electrical problem. Photobiomodulation and functional medicine don't really address neuroelectrical reorganization as directly as neurofeedback, which is specifically about intervening on and renormalizing the electrical patterns in the brain that connect all the different areas and provide the normalization of functioning. So that's where we think now the integration of neurofeedback with photobiomodulation makes a lot of sense as a clinical intervention, but also as a therapeutic, as a preventative strategy for people who are starting to see, I'm developing more amyloid in my retina scan than I want, and I'm now going to take seriously the idea that I want to manage my inflammatory processes to make sure I don't get worse. So these are some of the working hypotheses that we're operating on. And I think that it's going to be over time that we see that the whole idea of studying biophotons is going to be an important way of understanding the impact of photobiomodulation. And we know that EEG synchronization, which is in our language is called phase lock and phase reset, in the interhemispheric coherence, that's going to express the biophoton field state. So there's going to be this dynamic interaction. And so photobiomodulation is really going to facilitate that EEG coherence normalization. It's going to also support the neural reparative and anti-apoptotic functions and biophoton field functionality. This is the study that we published recently that has to do with the use of the Cognito light, which is this lovely little device. and it has 900 LEDs, and it's all wavelength is matched to 1065 to 1075 nanometers. The pulse rate is now at somewhere around 400, 480 hertz. That's what we used in Texas and in Philadelphia. And we broke it out into 2 sites, 60 people in Texas, 40 in Philadelphia. And we gave the people a quantitative EEG, which is a brain mapping process to understand where they're at in brain electrical terms. But then we also did a full neuropsych battery called the ADAS-COG, so we could then compare. And we did it at the beginning of a 2-month process. We did it at the midpoint, and we did it at the end. And so we collected that data. And in this study, we used only the cognitolight. We didn't do any neurofeedback. So this was people taking the device home, putting it on, pushing a button, and using it twice a day for about 6 minutes each time. They did it every day, twice a day for 2 months. The issue about penetration, which some people need to understand, is that the main blockage that comes from infrared light or light penetration is really the skin and the bone. And this was the data from a study done at the University of Bristol some years back. I think it was in 2000. And they showed that with patients who were undergoing neurosurgery and they had part of their skull removed, they were doing an experiment. They agreed to be part of an experiment while they were undergoing neurosurgery. Can you imagine? But they did. And so the light was put on their scalp, and the receiver was put at the surface of the cortex, and they measured all the different areas going from the cortex down, and they measured how much light could be picked up. And what they found was that the loss from bone was almost negligible, that the main loss was from skin. So if anybody who wants to get the best results for doing photobiomodulation needs to get the LEDs as close to the scalp as possible. If you want to shave your head, that's another matter, but get the LEDs as close as you can. So the other issue was that with the 1070, we were looking at the penetration pattern in the pure water molecule and showed that the 800 range was getting through the best. And then it dropped off really quickly, but then it came back up into the 1065 to 1075 range. But no one had really looked at what the biological impact was of this optical window compared to this optical window. So we're trying to understand how those two things might be different. So this is a poster that we just put up at the 2021 Alzheimer's International meeting to show the results both of the neuropsych testing, but also of the quantitative EEG. So what we saw was that in terms of mini mental status exam scores, there was a significant increase in the people who received active treatment as opposed to the control, the placebo control. And again, this was a randomized assignment, double-blind, placebo-controlled trial. So we were very excited about that. We then saw that there were reports coming from the caregivers as well as the subjects of people who were duly diagnosed both with dementia, but also with Parkinson's or a movement disorder. So those people started reporting improved sleep of over an hour and improved gait and motor fluidity, facial expressiveness, and diminishment of emotional and functional apathy and engagement more in social activities and activities of daily living after only a week to 10 days of the active treatment, and that it persisted throughout the course of the treatment. So that was really interesting to us, and it corresponded with some of the findings that we've had with some of our patients in the practice who have Parkinson's. So then when we started looking at one of the other very overt and immediately apparent tests, the clock drawing test, we saw a really significant difference that was almost a 70% improvement in terms of the scoring system that goes with the clock drawing test. So people who were getting the active treatment improved over 70% on their clock drawing test. So that was very impressive to us. when we looked at the quantitative EEG, we took all of the subjects, there were about 38 subjects that we had in the active treatment and about 20 some odd in the placebo. And we compared that, and we saw that with the active treatment group, in the QEEG, this blue area here is showing the post minus pre status of aggregate microvolt or amplitude change from the treatment. And so the blue is showing a significant decrease in that overall microvolt amplitude in the right hemisphere, and that this is directly associated with improvements in memory and executive functioning test scores. So this was very important to see because it really showed that there was an actual change in the brain tissue and in the brain functioning. This was the absolute power group mean change. And what we're seeing here in this red in the delta area, which is the 1 to 4 hertz. And the reason I'm showing you this is because the slow wave amplitudes, as I showed before with the neurofeedback, the slow wave amplitudes increase as people progress in dementia. And these were people who were diagnosed with mild to moderate dementia of like a mini mental status of between 15 to 24 out of a 30-point scale. So here at the baseline, we're seeing this significant amount of delta activity all through the frontal, down in through the prefrontal and into the sensory motor cortex. So what we were interested in then was seeing how would the light therapy affect. And you can see this is an almost below 1 standard deviation, and we've got normalization. The green is normal, it's the mean. So we're seeing a significant decrease in the overall delta amplitude down to this area in the right frontal area. Now, I think that this is compelling, certainly, and I think that with the neurofeedback, we would then be able to get a significant reduction in the frontal area by doing operant conditioning using the neurofeedback. So here with the sensory motor area, which is the 12 to 15 hertz area, that's what's considered the state of relaxed attention. So that when people increase their sensory motor rhythm, especially people with a attention deficit or depression, when they can increase the SMR, especially in the sensory motor area, which is right here across the midline, you see an improvement in their overall functional capacity for attention, concentration, and executive functioning. So here we're seeing that the baseline SMR was primarily back here in the parietal range, central, but then in the post-treatment, we see a significant expansion and increase into the sensory motor area and across the entire prefrontal and occipital region. So that's where we're at now is we've created a program, a new helmet that takes into consideration this 1070 nanometer light, but it's an actually easier to use. And it also includes the capacity to do something that we couldn't do before, which is modulate the pulse frequency and the intensity and the duration of stimulation in a preset protocol that we can set up for people. And then all they have to do is put the helmet on, turn it on, and push a button. And we can modify those protocols remotely over the internet. So what we've got now is this Neuradiant 1070 that's going to be coming out sometime in January or February. That we're really excited is going to be a way to deliver this kind of treatment to people at home with minimizing the exposure risks for infection with the pandemic, and also making it easier for people to just get into doing the treatment and in combining it with the other things that they're doing. So what we're going to be able to do is control the activity, the stimulation in the front, the left, the right, and the back of the head. And we can do them completely independently. So depending on what the diagnosis is and what the clinician's decision is about how to provide treatment, they can control where the stimulation is being delivered in those 4 quadrants. The stimulation intensity is based on the duty cycle. So you would get a 25, a 50, a 75% duty cycle, which would relate to intensity of exposure, but with pulsation. Whereas if you use 100% of the duty cycle, then there's no pulsation and you're getting continuous wave stimulation, which is a topic for another day, but it certainly has its place in the photobiomodulation realm. But I don't know how effective it is compared to pulsed stimulation in terms of dealing with neurodegenerative or neuropsychiatric or traumatic brain injury, things like that. So these are the specs for the new device. And comparing it to some of the other things that are out there, you know, we've got a four quadrant control in the Neuradiant 1070, whereas the Vlight Neuro, which is a device that I've used for many years and still prescribe and use with people, that has only a 10 hertz and a 40 hertz pulse rate. And then there are the devices that are out there where you can just put the probes anywhere you want and you get an LED probe, but most of those are in the under 1,000 nanometers range of stimulation. A lot of them have laser probes or laser diodes, but you know, there's a whole range of different things that you can do. And we're trying to focus primarily on how to integrate that photobiomodulation using near infrared stim and the neurofeedback. So that's kind of where we're focusing. And this is just the parameters for the helmet. So you've got the pulse frequency control, which is from 1 to 20,000 hertz. I hope somebody comes up with a paper that tells me why, you know, anything over 1,000 is worthwhile, but I don't know what that would be. And let's see. I think that's it for protocol control. You can do it, you know, anywhere. They're going to be a whole different set of protocol controls. And also the time duration can be anywhere from 1 minute to 30 minutes. So we're going to provide this device as a kind of simple 1 of 4 choices type of pre-programmed setup, but then also as a type of program that would involve the clinician working with the patient to design a very specific protocol based on the 4 quadrants. These are the people I work with at Neuronic, and this is the group in Ireland and in Munich, who will be setting up the company called neuronic.online, and they're going to be the ones responsible for marketing and promoting and some of the ongoing development in the research that we're going to be doing on this device. I think I better stop here and we'll take some questions.
Oh, that's perfect. That's perfect, Marvin. And I want to just chime in. First of all, you're going to have to get you a fixed mic because we heard clicking noises the whole time because of that little mic there. So either,
oh no.
No, it's not too bad. Either that, you have to become a little less Italian with all your hand waving. But what I want to comment on is that Dr. Berman was gracious enough to send some folks to me. One of them whom I would suggest is the toughest case I've ever experienced in terms of dementia. And she literally was sleeping 20 hours a day and the other 4 hours slumped in her chair. And I worked on her for a year with an anti-inflammatory, anti-infective program. And then Dr. Berman has introduced photobiomodulation and I think neurofeedback as well, stopped for a while and then reintroduced it. And I'm pleased to say that today, I've seen her, I've talked about her before, but I can see her pupils for the first time. In other words, even when she was awake, her eyes were shut. And she can walk with assistance. Since August, her gait has improved. She's communicating, she's pulling up words she hasn't had ability to find. When I met her, she was completely nonverbal. And now she is speaking contextually. And all I can say is we're going to continue heading in the right direction. Now, one risk factor she had is root canals. And at the time, there was no way she could go to a dentist and have any evaluation or treatment done on those root canals. But I think now we'll be in a position where we can actually get her to the next level of intervention. I know we have some questions out there, and I think Dr. Berman did a great job of answering some of them. I'm going to have you go first, Andrew, because I saw you unmute yourself. So just go ahead.
No, I joined late, so I didn't really catch enough context to press them this time, but I'll definitely be raring to go tomorrow.
Okay, excellent. Let's just see if I can go from the top here and see what we have. Let's see.
Sorry, I had to drop out for a second.
You're taking care of granddaughter, yes?
Well, a little bit, and the office was being invaded by the cat.
Okay. Yeah, so I want to know more about the light unit to place in your nose is a question by Doris.
If you mean by more, we have them available on our website. It's called the BioQuant NS, and it delivers a rather powerful level of light, and it can be manipulated a little bit in terms of pulse frequency. But I think the main benefit is that you can stimulate your whole body's blood supply through the mucosal tissue in your nose. You can get your whole body's blood supply stimulated. So all the mitochondria that's floating in your blood can then get stimulated and produce more ATP. What benefit that has when the blood gets to your brain, I mean, I can make a logical assumption, but I don't have data to back it up at this point. But we've certainly seen many reports online of people recognizing the value of photobiomodulation up their nose. I mean, they're talking about it in many different ways.
Dr. Harsfield, I want you to comment on what you think might be a value of doing the photobiomodulation in the capillary bed under the tongue. For Dr. Long.
Dr. Berman, great presentation, sir.
Thank you.
It kind of goes along with that narrative. Dr. Lewis has been expounding the entire time that I've been part of the group, is that a lot of these are sort of universal antidotes, so to speak, like walk outside and get infrared light, like walk barefooted and get electrons, like take water, sleep, things that are not so, like giving a blood transfusion. You got to be careful about that. This is another way to get energy into the body, and specifically in an area like the neurons. And also it's not, and I suspect it is, Dr. Berman, I'm really interested in how the things that we do for folks, how does that work on a molecular level? I love knowing what the microglia is doing when they're sick. They're making the lysosomes alkaline, and they're not supposed to do that. The oligodendrocytes in the brain aren't making the insulation. I mean, why are these people not acting the correct way? You give them energy, and Jerry Tennett's little device gives scalar energy. There's a level. These are biophotons. This is a way to get generically energy into a field, and then we need to back up and go, how'd that happen? I mean, I love what you're doing. And
well, I appreciate it. One of the things where we want to end up, and I'm really glad that you got to hear, because I loved what you were saying last time, and I thought that all these pieces really do fit in a nice way. Where we're going to end up, the kind of research agenda and the product development agenda, we're going to end up with the quantitative EEG mapping device inside the helmet. So the electrodes will be dry electrodes that when you put the helmet on, you'll automatically and immediately be connected, so that we can then start recording real-time EEG of 19 channels, which then we can pass through a normative database broken out by age, gender, and handedness. We'll also have a drop-down ear clip that will connect to the ear here, and we'll get heart rate variability data. So what we're going to build is a bidirectional guidance system based on normative EEG and HRV in real time. The algorithm that comes out of those two measures, which are basically, I think, really good measures for cardiovascular and neurophysiological functioning, we can then build an algorithm to drive the lights to turn on and off at the right frequency, at the right duration, for the right intensity, amount of time, as long as we're driving the Z-scores to 0. So all of that's going to be automated and in real time. So what people will get is that combined stimulation so that we know what we want to do with the biophotons based on the normative understanding of the EEG.
Marvin, I'm going to ask a naive question. Is there a possibility that your device also contributes to localized grounding in the brain?
I can't see how it wouldn't. And certainly the more normalized people's brain activity is, the more grounded, I mean, in a psychological sense, but also grounded electrophysiologically, they're going to be.
I'm assuming, and that question was for Judy, even though she didn't ask it. But I assume that your brain has some capacitor component, and that it may need discharge once in a while.
Well, okay, that to Dr. Hirschfeld's point, the Jack Tuszynski at the University of Ottawa is now talking about, and he's a colleague of ours, but Jack's been talking about, and he just published about how the microtubules are functioning as a capacitor and storing energy. So that capacitance function in the microtubules fits right in with what you were saying the other week.
Yeah, and that's brilliant, because the microtubules, when they undergo the hyperphosphorylation, they break up their sort of their crystalline structure. Right. They probably don't have the same capacitor.
They lose, the capacitor gets broken. Yeah, that's exactly it. I'm looking at the chat function. Should I just respond to those things?
I'll ask them.
Okay.
Because I've gone through them a little bit. So I'm wondering if Dr. Berman's program has a similar effect to Joe Dispenza. Do you know?
Yes. Yeah, sure. I think that the idea of integrating the psychological, the emotional, the spiritual, the bioelectrical, I mean, when you're intervening in the ways that we're talking about it with an understanding that there's an isomorphic principle. And isomorphic is a term from general systems theory that has to do with being able to observe a principle, a functional principle at every level of abstraction in the system, from the micro to the macro. So that idea of expansion and contraction and the normalization of being able to discriminate between similar and different, and being able to make finer and finer discriminations between similar and different, is a way of understanding that is isomorphic. And so what Joe and other people like that are doing is intervening in as many different ways as they can, but using essentially the same principle. So that's basically where we're coming from in terms of functional medicine, photobiomodulation, and neurofeedback as kind of the three-legged stool that we think makes a lot of sense. And we're working with Dale Bredesen and his RECODE program, as well as with Tom, and seeing how we can get people who are into the functional medicine, anti-aging world to then include the other two legs of the stool.
Excellent. What about the Neurooptimal system? Are you familiar with that? I'm sure you are.
Sure. So there's a Tower of Babel in every discipline. There's different language to describe the same things in every discipline and across disciplines. So Neurooptimal is a disruptive technology that uses the EEG and breaks up the chronic patterns of habitual response. I think that that's a very useful thing to do. I would prefer, and have have spoken with Val for many years, that what we want to be able to do is target that to some degree. We'd also like to be able to evaluate that clinically and scientifically. And there's just not a lot of interest yet in Neurooptimal being subjected to, the more traditional double-blind placebo-controlled trials to then publish about it. But I know lots of people who, say they get a lot of value out of Neurooptimal, and God bless them.
Are you treating chronic physical pain with this? I know that Dr. Carter's focus on chronic physical pain is the shock wave, the high intensity wave, but
I think that the shock wave, again, is there something about shock wave that's going to be more immediately beneficial? Yeah, I think so. Is the longer term, rebalancing of the system going to be of value in terms of maintaining improvement? Probably. Is there a formula for how those two things might be used? I hope that's what we're trying to do now, is figure out what the best mix of these kinds of interventions is going to be. But, anybody who thinks that they've got that worked out, I wish they'd give me a call.
what about EMFs if you have a Bluetooth component?
These have been, our devices have been designed to minimize EMF as much as possible. And the Bluetooth for the neurofeedback can be minimized by, extending the distance away from the PC, all you've got is a small amplifier, a small 4-channel EEG amplifier, and there's a Bluetooth USB plug that connects to the PC. So the neurofeedback is different.
I always remind people that it's all electromagnetic energy, and that infrared is going to be more intense in terms of energy, E equals H nu, than microwave. So the dose makes the poison. I've had people tell me they don't use a microwave oven. I say, well, you use an infrared oven, and infrared's higher energy. And so I say my basic plan on ameliorating the risk is I don't get into my thermal oven and I don't get into my microwave oven. That's how I ameliorate my risk. I'm being a little bit sarcastic.
A wise decision.
I think so. What is the website for Dr. Berman? And
QuietMind, the word quiet and the word mind, and then the letters F as in Frank, D as in dog, N as in Nancy.org. We're a 501c3 nonprofit, and we do not take money from industry for what we do. So we're a completely independent research group, and we also have our own human subjects review board. So we can do our own studies. We don't have to go anywhere for ethical approval because we have our own federal wide assured IRB. And we do support other clinicians who want to do research. We will help them with research design and then also with IRB approval. Obviously, those two functions are separate, but we can provide both of those for people who want to test out their own theories and their own way of approaching their work.
So how effective is this for depression or other mental health issues?
I think that's a really great question, and I want to answer it in a slightly different way. What we're doing with neurofeedback and with photobiomodulation and these types of interventions is we're addressing the underlying efficiency, functional efficiency of the central nervous system. So any disorder that might be in some way mediated by the central nervous system, if what we're doing is making the central nervous system function more efficiently, I think the question to ask is what's not going to improve? And there's a whole range of publications on the use of neurofeedback, and also for depression associated with traumatic brain injury, specifically with photobiomodulation and neurofeedback. My point of view is it's not really worthwhile, it's not really useful to get into the will it work with this, will it work with that, will it work with that, because really this is an intervention that's really at the zeros and ones level. So it's really addressing a much more fundamental issue about how the system is organizing itself.
Marvin, another good question, is there any time that there's a negative impact just from the fact that you're locked into some helmet from an anxiety of usage aspect?
Locked in?
Yeah, but that's a newbie.
You put it on for a couple of minutes and then you take it off. Now, if anybody's claustrophobic with something like that, we're going to have to think about their way of getting treatment differently. But I would say that someone who considers themselves to be hypersensitive, it would be extremely important for that person to be working with somebody like me or a clinician who understands that.
Yeah.
Okay, good. So anybody who understands, anybody who's concerned at that level should definitely not be trying this on their own. They should definitely be working with somebody who really can help them titrate the dose, right? I think there's somebody on here who could speak to that if he's around. Jim?
Jim whom?
I'm just going to say Jim.
Okay. Yep. I'll ask Jim.
Okay. All right.
Unmute. Anybody else have any questions?
Yeah, I got it unmuted. As far as the dose, yeah. Both my wife and I are using it, and in my case, it was good that he was taking a good look at me, because I actually had kind of a negative response to it for some beginning doses of 3 minutes on twice a day. I really got morose and really heavily depressed, and I stopped doing it and went back to 30 seconds. Whereas my wife, she's having much better reaction. She actually is the one with the mild cognitive impairment, and he's working with her on different frequencies and on different times, and she's had some really good positive reactions. And actually, just as the way I think she's having some positive reactions is she remembered a couple of words from that little, I guess it's that little mini MME test or whatever he was showing, right, the clock type test. But she remembered some of the magic words just on her own the other day. So something's happening to her. But yeah, definitely, two people living together, one of them has a bad result and one of them has a great result. I'm doing fine now, and I'm actually starting to get doing a little bit more as time goes on. But I'm glad I backed off, because I was like, what the heck is going on with this thing?
Exactly. Thanks, Jim. I really
there's no question, Jim, that I find people using the gut as sort of a corollary, that if your gut's a mess, a probiotic may send you into distress. But if you reduce that dose significantly, you may find that you can titrate it up over time. And so the difficult thing is, how do we measure where you are in the brain health continuum? And you're the best assessor of that, because we don't have great analytics. So everybody, I would suggest, probably starts low and works their way up.
Exactly.
Right? Yeah.
Exactly.
And some people like me start even lower. Yeah.
Yeah, we've had people. Okay, we got a mute issue. Okay, so I've had people with 20 years of chronic pain, and they started at 2 minutes of stimulation and started feeling like they were getting a headache, right? And I cut them back to 30 seconds. And this person had been struggling with this for 20 years. She called me the next day and she said, I did 30 seconds and an hour later, 80% of my pain is gone.
Excellent. Are there any contraindications like hydrocephalus or anything like that?
Is there a shunt? Is there a DBS? Is there any kind of hardware? We definitely want to talk, anybody who's got that kind of level of, challenge going on, we definitely want to do an assessment. Would there be an automatic negative impact? I don't know, but I would always want to start very, very conservatively with somebody with those kind of issues.
Rob asks, is it effective for hair loss? And then Marvin, we'll be a distributor. We'll be a distributor for your helmet when it launches.
That's fantastic. Yes, And yes, but it's certainly not, I mean, it's like to have the conversation about this technology as it relates to neurodegenerative disease, and then switch to, oh, and by the way, your hair will grow and your wrinkles will go away and your erectile dysfunction will go. I mean, we can't have that kind of conversation and have anybody take us seriously. So that's why I don't like to get into all that other stuff in the same interview or the same webinar, because it's just it's too snake oily. But there obviously are papers and research on photobiomodulation for all kinds of other surface level interventions. And we've designed the new unit so that you can switch to continuous wave, which is what's used in those other applications.
Well, I think the point, Marvin, when you talk about mitochondrial enhancement, most likely titrated back to blood flow, then we're talking about a multiplicity of conditions where this can have value. That's why I was suggesting under the up the nasal passages, under the capillary bed for more general therapeutic benefit, like you're doing whole body infrared.
There are people there are people working on, putting the device. In fact, the people in China that we've been working with have put up a device like this, and they've got probes that'll go in your ears.
Right. Now, for our Zurich colleague, he wants to know if there's a way to get the device to test with and on his patients.
Absolutely, and I was hoping that we would be able to have a conversation offline about that.
I'll connect you two guys.
That would be brilliant.
So anyway,
because the homeopathic, I mean, one of the answers to one of the questions was, how do you measure? Well, if you've got somebody who's a really qualified homeopath, they have technology that can really measure and show what's changing and how, and then what remedies need to be delivered based on the response that people have had to the stimulation.
Yes, and Steve, I got you covered too. I'll connect you to Dr. Berman as well. So any other questions? I think.
Yes, Dr. Lewis, what would be the protocol for someone using the helmet? Is that a short-term thing? Would you use it the rest of your life? How does that look?
Yeah, you're going to use this from a treatment point of view of remediating a problem. You're going to use it for remediation. For people who want to prevent, you're going to use it as a preventative. And so we are trying to build this in a way that's it's going to last for a long time.
Yeah, and I think Dr. Berman is being obtuse a little bit because everybody's different, like we spoke in terms of an actual treatment protocol. And I don't recommend anybody definitively say this is exactly how you follow this through.
Oh, let me be unobtuse. I don't believe in there being any kind of cookie cutter protocols for anybody. So I don't do that. I think there needs to be, an evaluation done by a qualified professional, and then using this technology, because it's too easy for people to think this is, a new toy that they can play with, and it's not a toy.
I'm just going to take Dr. Steve's question. That'll be the last one. But have you noticed any reduction in brain stem inflammation to restore cranial nerve function?
Yes, and especially when you direct the stimulation, when you're directing the stimulation back down toward the base. The one of the other devices that we worked with, that original device, the Cognitolite, has an array that goes down to the base of the skull and below. And I think that with that or other devices that can stimulate the base of the skull, when you combine that with neurofeedback that is specifically targeting cerebellar function and brainstem function, which we can now do using something called SW Loretta and NeuroGuide, you can now train the cerebellum. And I think that's where we're going to see a whole new level of improvement in those treatments of people with, subcortical pathology.
And I have to have Dr. Harshfield end with this question. I know he's going to make a comment on liberating the C1 vertebra as part of that process. So we don't.
Absolutely.
Dr. Harshfield.
You know, Dr. Berman, that's really interesting. We're finally realizing now the cerebellum, the little brain, lives in an eighth of the volume of the big brain. It's got
Yep.
80% as much surface area, probably 6-7 times more neurons. And every cranial nerve, except for 1 and 2 and 3,
Yep.
go right through there. So what
I
a
know.
great way to treat the brainstem, the limbic system,
Yep.
the cranial nerves. I mean,
And
it's
if we
awesome.
can, right, and if we can now use the SW Loretta as a way to map the different areas, just like we did with Brodmann, we can now begin to start mapping the cerebellum and get better targeting of neurofeedback training, which is basically reward conditioning, right? It's reward conditioning of somebody watching whatever they want to watch on the screen, and the screen brightness and volume drops instantly whenever somebody's not meeting the protocol.
Could I make
And then
a quick
it comes
comment?
back.
Could I make a quick comment? I'm a chiropractic neurologist and certified in QEEG neurofeedback. But one of the things we're just talking about stimulation of C1, and you know, my experience that in concussion there's two components. One is the cerebrum and one is the neck. And for successful treatment of traumatic brain injury, particularly auto accidents, you have to solve those two problems. And if you don't, patients don't get better, at least on a chiropractic standpoint. Just wanted to throw that out.
Oh,
No,
no,
I agree.
and the people, Matt Antonucci and Freddie Garcia and I are working on a webinar now to present all of this material to the Carrick scholars who I've already presented to. And I think that, you know, this is going to be a tool for chiropractic neurology that's going to take the whole field, you know, in a much better direction and a much more effective direction. Thank you.
Dr. Berman, thank you so much for presenting today, and you'll be back tomorrow night at 8 p.m. Eastern.
Yes, I'm going to do this again, but Tom, you'll consult with me about microphones.
Yes, we will. Thank you.
I think it was his
Dr.
microphone that was, it was his
Oh.
microphone that was touching the
It was.
table.
It was.
Touching the table,
Yeah.
not in his ears.
It was touching his butt. Anyway.
Oh, yes.
We'll
Okay.
get them all hooked up to us. Be all set.
Okay,
Thank you,
thank you.
doctors.
Thanks, Dr. Berman.
Bye-bye.
Thanks very much.
Thank you.
Thank you, Dr. Berman.